and I'm so excited to be joined today by Dr. Heather Riordan from Kennedy Krieger Institute in Baltimore. And today we're going to be talking about motor disorders in cerebral palsy, the different types, maybe why that's important to know, and different elements of potentially what we can do about it. So Heather, before we get started, could you just give a little bit of the audience a background of what you do and even why you got into this field?
Oh, that's a great question. So I currently work as the medical director for the Phelps Center for Cerebral Palsy at the Kennedy Krieger Institute. I honestly didn't anticipate that I was going to do cerebral palsy when I first started out my career. I started as studying movement disorders in general in pediatrics. Of course, cerebral palsy becomes a really important part of that, and kind of fell in love with it over time. And now I've chosen to make it the entire center of my career. I also have a brother-in-law who has cerebral palsy, probably in the background influenced me somewhere in there with that.
And your role as a neurologist, when we're thinking about cerebral palsy, both in diagnosis and the treatment, what do neurologists usually do thinking around cerebral palsy?
So the neurologist's role in cerebral palsy will vary significantly from institution to institution. In general, neurologists are heavily involved in the initial diagnosis of cerebral palsy, particularly if any imaging or genetic workup is necessary to make that diagnosis. Additionally, they may be involved in epilepsy or treatment of other neurological co-occurring conditions that may occur in cerebral palsy. In some centers, neurologists are primarily involved in the care of tone management and long-term management. In other places, you have other people like physical medicine rehab doctors or developmental pediatricians who are the primary providers for those types of care. And in many centers like at Kennedy Krieger, there's a mixture of different types of providers who are involved, including neurologists, PM&R doctors, and developmental pediatricians.
Yeah, absolutely. And I think when we're going to get into, talking about the motor disorders in cerebral palsy, there are obviously different types. We just go over the different types? And if everyone who is watching, if you have any questions for Dr. Riordan as we're going through, please put them in the chat and we'll make sure we try to answer them as we go.
So when we think about cerebral palsy, you can divide it in different ways, but perhaps the most important way to divide it is by what kind of movements we're seeing, or we'll say phenomenologic or phenotypic categorization. The most common movement we see in cerebral palsy is something called spasticity. And this is defined by when you rapidly move the muscle, it kind of tightens up. It's similar to what we see in reflexes, where you suddenly hit a muscle and you see it pop up. The second category of types of movements we see in cerebral palsy is something called dyskinesia. And dyskinesia is kind of a catch-all term that includes dystonia as well as something called choreoathetosis. Dystonia is a group of movement disorders where you get this slow postures that are oftentimes stereotypes. So you may see the same posture over and over again that comes out more when the individual is excited, in pain, under stress, or stimulated in some other way. They can have a twisting quality to it, although it does not have to. Some of the things that really tip me off to thinking about dystonia is when somebody is having times where they're nice and loose and other times really tight, although that can be difficult if they also have spasticity. If you see kind of swanning fingers, arms pulling back and twisted, those are some of the more easy things to key on. But sometimes it can be much more subtle, and it's important to differentiate from spasticity because while some treatments address both, some treatments may be different between the two.
I was going to say, you just brought up a really good point, though, that some people potentially have both.
Correct.
So you said, obviously spasticity is the most common type of cerebral palsy, but there are many people with spasticity that actually also have dystonia. And can you just sort of describe how that can be presented, what that can look like?
So the truth is that oftentimes it can be difficult to differentiate how much of somebody's movements are due to spasticity or from dystonia. But it's important to note, because it does sometimes change treatment, and especially if the dystonia or the spasticity is causing more difficulty with function than the other. We used to feel like spasticity was just 80%, only 10% of people have both. Now we know that it's closer to 55% of people have a mixed phenotype. So it's kind of challenging this way that we've always thought about cerebral palsy, where we had these nice little categories, that maybe we need to think about it in a much more complicated way. as thinking about them as groups of movement disorders as opposed to distinct entities.
So that's a pretty big change, right? Like thinking that it was potentially only 10% of those with cerebral palsy that had dystonia or dyskinesia type cerebral palsy, and now thinking that it's up to 50%. So some of you watching actually might be go, hang on, I got diagnosed with spasticity. I have, the spastic form of cerebral palsy. What should they be thinking about that? Like how, is it something that they would need to potentially have a conversation with their doctor about to say this is important to understand because, as you said, interventions might change? Because I imagine a lot of people listening and going, oh, hang on a second, what does this mean for me?
Yeah, no, absolutely. So what a recent study has shown is that more people have a mixture of dystonia and spasticity as their cerebral palsy movement disorder than people who have spasticity alone. So if you do have some of these other moves where you're like, wow, when we hear about dystonia, this sounds familiar to me, absolutely bring it up with your physician, because it may change what types of treatment options are available. There's some medications that work for dystonia that don't work, that aren't usually used in spasticity. Similarly, there are some there's some surgical options and things like that that work really well for spasticity, but may not help with the dystonia. So it's really important to differentiate those two things. And I think it was also helpful for you to have more understanding of your own body and how it works and interacts with these movements and why your body may be doing things that's different than other people that you see that have pure spasticity.
So this is sort of like a new thinking that we have as a field, that obviously dystonia is more present than we actually originally thought. How do you test for it? Like, how do we know if somebody has dystonia? Is it just from looking at their movement, or are there specific tests that can be done?
Absolutely. So this, I think, in the end, dystonia is a clinical diagnosis. We don't have a blood test that shows that there's not some sort of an EEG exam that can say, yes, this is dystonia. There are some other research level tests that you can use, but we don't use those very often in the clinic. There are some scales that can be, in addition to knowing what dystonia feels like, what it looks like from reading about it or from looking at the patient, or experience. There are some tools that we can use to help differentiate it. Most commonly is the hypertonia assessment tool, or the HAT scale, that can help to differentiate what's spasticity, what's dystonia, and see if somebody may actually have both as opposed to pure spasticity or pure dystonia.
And as far as like thinking about who might be able to implement that tool or look at that from an assessment perspective, is it sort of a neurologist and a movement specialist that will probably have, I suppose, the most understanding around this? Because obviously it is a changing in thinking for some who may think, okay, yes, spasticity is the primary type and that's really all that I see, even though dystonia may actually be there.
Yeah, absolutely. I mean, there are a group of neurologists that focus on movement disorders, but I don't think it has to be a movement disorder neurologist who uses this tool. There are many PTs that are certified in the use of this tool and have experience with it. And similarly, there are a lot of physiatrists or physical medicine rehab doctors who also have some experience with it. But again, I think every team is so different depending on what part of the country you're located in and what your center, how your center is built. So I think that's where going to your providers and saying, hey, we've heard about this thing called the HAT. What do you think about it? Do you think it could be helpful in differentiating these things? Do you think it could be helpful in guiding my goals and my treatment?
Because I suppose that's why we're talking about this, right? Is because, as you had mentioned a couple of different times, the different treatments that would happen between something for spasticity compared to, say, a dyskinesia or a dystonia. Can we sort of go through those a little bit? You mentioned surgery and pharmacological treatments. Maybe saying in pharmacological treatments, what are the sort of things that can actually help with interventions?
Yeah, so I think one of the most important things to know about dystonia is it can be triggered by things like pain, anxiety, distress. So sometimes the best way to treat dystonia is actually to be looking at those things, but to understand that those things are triggers and to pay attention to that. If it's really hard, even keeping a diary can be really helpful because those are very low-hanging fruits that we can use that help a lot with dystonia. I mentioned that SDR is very helpful for spasticity, but may not be helpful for dystonia. There are other surgeries that we'll use for really severe dystonia, devices called a deep brain stimulator, another surgery called pallidotomy that may be helpful for dystonia but wouldn't be used in spasticity.
Sure.
Similarly, while muscle relaxants like baclofen or dantrolene can be helpful for both spasticity and dystonia, there are some medicines specific to dystonia. So medications like trihexyphenidyl, carbidopa, levodopa, or medicines like clonidine can be very helpful in dystonia, but may not be thought of in the world of pure spasticity. So again,
Absolutely.
this can offer us new treatment options that we wouldn't have if we thought about this as a pure spastic syndrome.
For spasticity, I think there's a fair bit of information out there around, say, for example, strength training and exercise and the benefits of that on overall muscle and bone health. Is there similar evidence around dystonia as well? Like, obviously pharmacological treatments, surgical treatments, it's really good to be aware of those, but what are the other types of interventions? Like, is PT, OT, do we have evidence or do we need to do more?
I think the evidence is starting to grow in terms of different things that can be helpful for dystonia. A lot of the literature that we have, though, on the effectiveness of therapies in dystonia is really coming from the adult literature from people who have other types of dystonias from various genetic disorders and things like that. So we really need to bolster what we know about the treatment of dystonia from a therapeutic standpoint in individuals with cerebral palsy. But we are growing more data for this. I think there's a lot of attention right now on the sensory component of dystonia. As I mentioned, dystonia comes out more with stimulation or different emotional triggers, pain triggers, things like that. So thinking about how those things interact and how we can intervene on that level to help with dystonia, which may not be true for spasticity, is really important.
So one of the questions that just came in is like, what are some symptoms or what do people potentially look for, or how do they describe dystonia when they're coming in?
Absolutely. So one of the unfortunate things is that I think sometimes we don't give patients language to talk about this. If we're not bringing it up, they may not have heard about it, or they may not know how to describe and separate it. So sometimes when people come into me, they do use terms like, oh, it's my muscle spasm or my spasticity that's acting up when it really may be dystonia. Some of the other things that people will tell me is that they have uncontrolled movements, that they have extra movements, or that maybe their arm or their hand just doesn't listen to them, that it does its own thing because it's having an extra movement that they didn't tell it to do, which is different from spasticity, which is more just that tightness when they try and move.
And obviously cerebral palsy we know is different for everybody, but dystonia particularly, does it really present differently in everyone that comes in?
Absolutely. I think not only in location of where people have dystonia, but in some patients, it's more just very subtle postures, and other people it's much broader, bigger movements where that in severe cases that can cause things like dislocations or even fractures if they're severe enough. So there's a very broad spectrum of what dystonia can look like. And I think that's part of what makes it difficult to diagnose, because many people are basing it upon one period, one little experience they've had, as opposed to this broad spectrum.
And you brought it up a little bit before that sometimes movement patterns do change over time as we age and as our muscles grow and those different things, and potentially as we do new activities, some things might become more present. But how do you see dystonia impacting people functionally? So, and then I'll ask you another question is, does it always need to be treated? But
Absolutely.
if we're thinking about functionally dystonia, what do we see? Is it things like, is it everyday activities that it impacts people the most, or what do you see the most?
So I'm going to answer your first question first, because I think it leads into the second. And that is that it doesn't have to be treated unless it's impacting somebody's quality of life and function. So if the dystonia is there, but it's not bothering, somebody as much as the spasticity, it's not causing problems, we don't want to treat something and then potentially give side effects if it's not impacting their quality of life. Ways that it can affect quality of life depend very largely on the severity of the dystonia and where it is, and also what the patient's function is outside of just the dystonia by itself. So in more subtle cases, I find that fine motor control is an important thing to pay attention to. So if you have some tightness or posturing of your fingers when you're trying to do things like cooking or writing, that can have very significant impacts on function. In other cases, it can affect gait or walking. For more severe cases, it can cause pain or discomfort. It can affect ability to dress, to change diapers, those basic, cares that we all need. So it can affect people in a lot of different ways.
So sort of going on from that, like thinking about can it be improved, I suppose? And, I know that's a big question. We think about cerebral palsy and what's functional improvement, what does improvement mean? But yeah, the treatments that we currently have, do you see that any improvements can happen?
Absolutely. So unfortunately, we don't have a cure for dystonia at this time.
Mhm.
I hope by the time I retire, we'll have a different answer to
Yeah,
that
we all want to be
question.
out of business. There's no doubt about
Exactly.
that.
Yes. Please put me out of business, you researchers out there. But in terms of the actual treatments, I think it's very individual. So unfortunately, when we don't have a silver bullet for dystonia yet, some patients respond really well to some medicines, others to other medicines. So it can be a frustrating process for
Sure.
families and individuals in terms of going through that trial and error experience. I will be honest that sometimes dystonia can be hard to treat and find the right treatment. And I think that's where identifying it and having those really important discussions about, what your values are, side effects versus function, what your own personal goals are, and how much of your function is being affected by dystonia versus spasticity is very important. But I definitely have seen some people who have had really good improvement with the right medication or the right surgical or other treatments.
So we mentioned chorea before, and we've sort of that they are different, right? So what we would see as a dystonia compared to, say, a chorea, and how they present differently. Do they get treated differently as well?
Sometimes, yes. So there are actually some medicines that can improve dystonia that can potentially worsen chorea. And the alternative is also true, that there are some medicines that we think about with chorea that can potentially worsen dystonia. The challenge is when you have both together, you have to really be thoughtful. One of the best pieces of advice I received when I was early in my training is find the movement that's causing the most problems with function and focus on that first.
Sure.
And that can be very helpful.
Oh, and I think that's where dystonia and actually understanding dystonia is really important, because it really can impact those functional activities, as you've discussed.
Exactly.
So it's really important to have those discussions with your physician, with your doctor, with your providers, to really find the best treatment options for you, because we do know, unfortunately, with cerebral palsy, it's not one size fits all.
Absolutely.
So I know we've got some really interesting questions coming through, and thinking about, and I'll just ask one more before we go into them, but thinking about, okay, if someone's listening right now, they go, all right, do I have dystonia? Do I have spasticity? Do I understand my motor type? Yes and no. Obviously, we've discussed, well, who you could actually go see to help with that process. But what about thinking about future research? We've talked about that there's gaps in the research. Where do you see this sort of going as far as potentials for people to potentially participate in different research studies that are happening? Are there things available around dyskinesia and even different motor types in general?
Well, I think there's a few different layers to that. I think that there's some drug trials for different medications for dystonia, including primarily VMAT inhibitors. There's a couple of them going on right now. And we're really hopeful that those will have positive results so that we can have a good FDA approval and get them through insurance to get better treatments for our patients.
So I'm sure a lot of you, if I'm listening, I don't know what a VMAT inhibitor is. So can we sort of discuss the mechanisms on how some of these things work? So, understanding that really dystonia and dyskinesia as motor types, what is it actually doing?
Yeah, so chorea and dystonia are complicated. And, a lot of times when we're thinking about the brain, we think about certain parts of the brain. But what we know is that it's not just the anatomical part of the brain, it's the signaling pathways of all the things like dopamine and serotonin that are going on in the brain that really make a difference in how our brain functions. We know that dopamine particularly is very important in these dyskinetic syndromes. What a VMAT inhibitor does is it decreases the rate of release of dopamine from one neuron to another in a way that helps to decrease this aberrant signaling that's going on in the brain, hopefully, and in that way decrease the amount of abnormal movements that we're having.
Sure. And so now I've got a question that's come in from someone who's tried different things in the past. and I think there's different things around. So say epilepsy, for example, we know that if multiple drugs are tried, then sort of the chances of a new drug working, things like that, sometimes decreases for people. Do these get used in combination with other drugs? Are these things that people can be on and be on, other medications as well? Or is that really depend on the medications?
So in terms of the VMAT
Yeah.
inhibitors, absolutely, they can be combined with other drugs, but you want to be careful and thoughtful about what you're combining with. There are certain medications that may have interactions. There are certain conditions that may put you at higher risk for side effects. So you definitely need to be talking to your doctor, but we very frequently are using these group of medications in conjunction with other medications, both for dystonia as well as for other conditions like the epilepsy or drooling or attention or whatever else may be affecting the person.
No, I think it's really important because I think that's maybe sometimes not discussed enough, just how much potentially different drugs interact with each other.
Correct.
There's another question coming in. Can someone develop dystonia or chorea? Is this something that if they didn't have as a child, they can get it as an adult? Or is it something that we know, okay, that would be your motor type forever? Maybe it just wasn't diagnosed.
So I think there's a few things that's tricky about these dyskinetic symptoms. And I should mention, we defined dystonia. We didn't really define chorea.
Sure.
Chorea is another dyskinetic symptom that's characterized by more fluid or jerky movements that go across joints, kind of move from one part of the body to another. With both of them, with people with cerebral palsy, for reasons that are not fully understood, sometimes you don't see them very prominently in early childhood, but as a child gets a little older, 5, 6, or even as they hit puberty, sometimes you see these movements popping up more than we had seen previously.
Sure.
So certainly that's where serial exams and long-term relationships with physicians can be helpful, and being thoughtful from one time to another if you're seeing something change to have the discussion. The other thing that we always want to be mindful of is that we know that at least almost a fourth of people with cerebral palsy have a genetic contributing factor. And for many of these people, there may be a genetic cause of that also predisposes them for dystonia. And sometimes that can change over time as well. So sometimes we see somebody who's diagnosed with cerebral palsy and they suddenly develop severe dystonia. We realize that there's an underlying genetic cause that may help explain that. And knowing that can sometimes change what kinds of treatments we think would be most helpful.
Yeah, absolutely. So with the different types of, obviously, motor types, one thing we didn't really talk about is it different areas of the brain that are damaged? Is it different areas that are impacted that are leading to these different motor types and the signals that are going to the muscles?
So the answer is yes and no.
Okay.
So historically, we know that there are certain parts of the brain that are more involved with dyskinesia, particularly these deep gray centers very deep in the brain called the basal ganglia and the thalamus. These parts of the brain are also involved in other movement disorders like Tourette syndrome, Huntington's disease, and Parkinson's. So if we see injury there, certainly I'm going to watch that patient more closely for dystonia. All that said, there's an increasing body of research that shows that people who have no evidence of basal ganglia injury on their MRIs, that have injury in other parts of the brain, can also have dystonia. And so we need to be very careful about being too confident in looking at that MRI and prediction of what motor phenotypes an individual will or will not have.
No, I think that's really important as we're learning more, right? Like, I think this is an evolving area, both of understanding, but also research. So it really is sort of like in the next couple of years, we'll have a lot more understanding, which is a wonderful thing to do. But also for any of you listening, we've got incredible resources on cpresource.org, which go over different motor types, different opportunities. We also have a series around clinical trials and research that's happening in the US. So if you do want to look up any options and any opportunities for you or your child, they're all there. But Heather, I just want to say a huge thank you, obviously, for joining us here today. And again, any other questions, we'll try to answer them in the chat. Thank you so much.